Carol, thank you so much for that introduction. So in this next session, we're going to have three panelists and moderated by Dr. Jerome. I'll introduce the panelists in a moment, but the focus of the panel is really about how research can be conducted in low-resource settings, and each of our panelists is going to speak from their first-hand experience on the various ways in which this has been achieved, for example, through establishing strategic partnerships, and also, importantly, how you can translate the knowledge that is actually generated into policy and practice. But I hope the panel will also address what I think is perhaps a bigger elephant in the room, which is, in fact, oftentimes the dilemma between conducting research in the first place in contexts in which there is a very large unmet need for care, but also the other very important dilemma about who actually sets the agenda for that research. We've heard, some elements of this in the earlier panels, but I hope that this panel will also address that. Speaking from my own experience as a mental health researcher who began work in low-resource settings back in 1993, I can tell you firsthand these are very huge questions, because back then, of course, the entire global health research agenda was dominated by one disease called HIV, and nobody wanted to listen to absolutely anything about any other form of suffering. But equally, that in the very places where I was working, where most people received no mental health care at all, questions were asked whether the precious dollars that were being spent on research that I was asking for actually were well spent, and whether they should in fact be allocated entirely to service delivery. So I'm hoping our panelists will also really address some of these questions. So let me introduce the speakers. We've got an incredible panel here, and I'll invite these speakers to please come onto the stage here. Dr. Sikhulile Moyo is the laboratory director of the Botswana-Harvard AIDS Institute Partnership and a research associate with the Harvard T.H. Chan School of Public Health. Dr. Aima Ahonkhai is an associate physician in medicine and an associate director of the Biobehavioral and Community Science Core at the MGH and a director of the Community Engaged Research Program at the Harvard University Center for AIDS Research. And the final panelist is Dr. Pham, is an associate professor at the Harvard Medical School and at the Chan School of Public Health. She's the director of education at the Harvard Humanitarian Initiative and a co-founder of KoboToolbox. And lastly, our moderator for this panel is Dr. Gregory Jerome, who is a senior advisor on health system strengthening at PIH in Haiti. Over to you.
All right, thank you, Professor Patel, and good afternoon, everyone. So now we are at this panel session to follow some really good conversation that we have had so far. Okay, that's good now. We have had so far this morning. So we have this wonderful panelists to really this kind of conflict or tension that we see in the global health context, and the way that we would like to really frame our discussion today is looking at health organizations delivering health services and public health intervention, usually present themselves as learning organization, meaning that not only they provide care, but also the ambition, or they have the aspiration to also learn from their practice, from the implementation that they are doing, to also conduct research, generate evidence, and also share with to contribute to knowledge generation. And but in many situations where this overall organization orientation combined with individual interests for research, we see that there is still a low productivity, especially in the context of low-income countries. And that really make us question, what are the elements, what are the factors really that contribute to this low productivity while there is like high interest for research activities on the ground, and coming from staff working for those organizations in this context. So we'll try with the panelists that we have to see the different angles of this issue, and we'll be looking at different aspects of it, looking at what are the factors that really can kind of explain this tension and this low productivity, and also looking at the different contexts that we have in the U.S. versus like the global South, I would say. We also have the opportunity to have some of the panelists talk about specific contexts in this situation, especially in the context of pandemic and pandemic preparedness, pandemic response. And also, I heard from the previous panel discussion that started really around funding also for research in this kind of tension. So with that, we will hand it over to our esteemed panelists to tell us, what are their initial thoughts about this issue from their practice, from their experience, how they have really witnessed this kind of conflict on the ground, and to share with us. So we'll start with Dr. Moyo.
Thank you. Thanks, everyone, and thanks to the HGHI for the opportunity to share our lessons in global health, involved in research, service delivery, training, and capacity building. I'll give you two perspectives so that you understand where I'm coming from. An individual perspective, where I've come from in global health research, intersecting with training as well as a trainer, and being trained through the system, and also ability to intersect with our service delivery programs, as well as conducting research, and so being in that intersection. But also belonging to an organization that has been born since 1996, the Botswana-Harvard Health Partnership, it was formerly called Botswana-Harvard AIDS Institute Partnership, really born from the height of the pandemic. If you knew, Botswana had the highest prevalence of HIV in the world at the time, at the ANC prevalence ranging around 41%. In the early 2000s in the ANCs, and with the remarkable success that you have seen right now. So BHP was born from Harvard, collaboration with the Minister of Health, a president in a conference. They meet one of the founders of BHP, Essex, from the Harvard School of Public Health, and they discuss about solutions. So really, what are the solutions? What is it that we can put in on the table to provide solution to a huge program where at the time the president described our population is going extinct because of HIV. So that's how the organization was born, as a partnership with the Minister of Health to provide training, a research program, and capacity building program that really established one infrastructure, partnering with the government. A very big 3-story building, 25,000 square feet was built, focusing on HIV. Opened up one of the first clinical trials for HIV with the newest of the drugs, the first clinic to attend to ARV patients in Botswana through that partnership. And 2 years later, through that partnership, the government decided to earmark its dollars to provide free ARVs, the first country in Africa to do that, to earmark its ARV funding to provide ARVs for free to all its qualifying citizens. Today, Botswana was one of the first countries to achieve the 95-95 UNAIDS goals because of that decision, supported by evidence-based research and capacity building. So BHP started a training program for healthcare workers, a tailored program we call the KITSO, that really taught AIDS care fundamentals, as well as providing basic research some of the early clinical trials on mother-to-child transmission. Maybe you know the MASH study, one of the groundbreaking MASH study. One of my mentors is here, leading in that study with Roger Shapiro and Essex. Shane Lockman is in here. So that partnership, for me, is one of the models that has grown to provide an intersection in informing the Minister of Health and the public sector in terms of what is the problem, what are some of the solutions that we can do, and of course providing cutting-edge research to really inform the intervention. From being a public institution, so that becomes always important discussions. Transparency, communication, making sure that there's always transparency about what needs to be done. So that's a big picture about an organization that is really rolled up and being in the forefront of HIV care. And here I come in, 2003, I meet Max Essex. My background, originally from Zimbabwe, trained in a rural Zimbabwe, didn't know what the future would be like. A priest pays for my school fees. I get access to an education. And I decide, okay, I'm gonna have my first degree across the country and live in Botswana. And I meet Max Essex, exposes me to health research, Fogarty training fellow. I land in Boston. Very cold, but learned a lot. Blown away by the resources, the people, the energy, but hungry to go back home because I knew the kind of poverty that I lived in. And went back home, and I can tell you that over the years, to be one of the first individuals to discover the Omicron, and looking where I'm coming from, really in an environment of training and capacity building, for me, has been outstanding. Of course, with the new generation now leading the institution now as the director of the research program, we host Harvard undergraduates for internships and we pair them. We try to make sure that because I've been exposed, I understand what exposure means, so we try and bring them to Boston and other universities as well. So there's so much that can be done. The funding is very little. The demand is so much. So we need to think about how to really do capacity building and partnerships in the new era of the problems that we meet. So I count myself privileged, but there's hundreds of people who are looking to us, looking to everyone in the room here to change the narrative about true capacity building, not just one direction, but bi-directional. So we've insisted on bi-directional partnership. A student comes, we pair them. A fellow comes, they work in a hospital, they are paired. And that's the model of mentorship that brings true partnership. Of course, there are limitations in funding. People who are doing service, very little time to do research. They don't have FTEs. So when you say you bring fellows for training, they have protected time, but their counterparts don't have protected time. So what mechanisms of funding can allow us to really make the capacity building and the training be a real bi-directional? So I'll leave it there. Just some thoughts, and we'll come back to this later.
We'll come back to Dr. Moyo on those different points. So we'd like to hear from Dr. Ahonkhai on this.
Sure, thank you. Thank you so much for having me here. I think we've heard some themes that have been coming across again and again today that are quite important. And one of those is power, of course. There's this old saying, until the lion learns how to write, every story will glorify the hunter. And so we've spoken a lot about who has the power and the relationships and the research. I'm talking to you from the perspective of a researcher, of course, at Harvard, right? I'm also of Nigerian descent. I'm also clearly an African-American female in this country. So I think understanding my power and position is critical. And as researchers, we all have to do that. Who has the money? Who has the resources? Who has the political will or connections? And who sets the agenda? And these are all very big, sometimes existential questions that we've been asking ourselves today. But as an individual researcher that I'm representing today, we all also have to figure out how to answer those in our day-to-day practice. The other perspective I bring is as someone who does global health research and domestic research in the United States, both focused, whether globally in Nigeria, which is where most of my research is based, or in the United States on minoritized, often marginalized communities of people living with HIV. How do we build partnerships, collaborations with communities, either globally or locally, that are actually empowering and listening to the voices of those communities? So I think I'd like to really share opportunities for what has been successful. None of this is easy, as we all know. None of this is easy, but we have to find ways to do it more effectively. So power is one point to raise. Another is incentive alignment, and you mentioned some of this, Dr. Moyo. As a researcher in an academic institution, what is my incentive? It is grants, it is papers, it is more grants. Maybe I want to be promoted, maybe not, but you have to get grants and papers to succeed. What are the incentives of my partners? So if I'm thinking about my partners in Nigeria who are on the ground providing frontline care or trying to implement all of the programs we say are so important, is there incentive to send me a biosketch? Is there incentive to edit this paper? What are the incentives and what are we rewarding? And what am I punishing? You know, when I'm talking about my community partners in the United States, and some of my friends and colleagues here know that I've been working quite a bit with barbers in the United States as community health workers that Nico mentioned. What is their incentive to be involved in this partnership and try to address Black men's health needs in the US South? Is it publishing a paper? Of course not. So what are the incentives of our partners, and are we elevating those incentives in whatever framework it is that is bringing us together? So I think incentives is another critical one. What is the infrastructure in which we're working? And again, you know, from the perspective of someone who is writing grants in a not ivory tower, I have the infrastructure of an amazing grants administration team. What about my partners in Nigeria? When will they get the resources they actually need to do this work? And what kind of safety nets are in place to make sure that they may be whole in the interim? I started out working with an organization like yours that was a partnership between Harvard and the AIDS Prevention Initiative in Nigeria, which has also become its own organization. And they're quite a big organization, and their budget now has the capacity to kind of wait for that 6 to 9 to 12 months for funds to come from the NIH to whatever U.S. institution to them. But many of our partners don't have that capability or flexibility. And it's a really artificial thing we're imposing on them if the goal is to do the work or to do the research or to do the implementation. And then I think we've also heard about how and whether research is getting integrated into policy and practice. I work a lot with adolescents and young adults, and you know, leave it to younger people, younger than yourself, I should say, to tell you the exact truth about what you're doing. And so, you know, whether it's interventions working in an M-health space, mental health space, some of my work, as the studies are ending, the youth are saying, wait a second, it stops today, and then what? And then what? How is it being integrated into policy? And we can wax prolifically with our peers who know that what all of the challenges are and how difficult it is to get policy into practice. But if you have a 13 or a 15 or 17-year-old young person living with HIV who you've just, you know, exposed to an intervention that they think is helping them, and you're now taking it away because the funding has ended, it doesn't make sense, and it shouldn't make sense. But this is kind of the system that we've created for ourselves, and we've gotten used to. So I think those are some of the themes that I would want to highlight. But I think, like Dr. Carey said earlier, we all need to be disruptors in a way, in our own way. Maybe it looks different for each of us, in how we are conducting, whether it's our research or advocacy, whatever space we're working in, making sure we're effectively collaborating and elevating the voices of our partners, making sure that we are integrating capacity building, as you mentioned, and whether that means sneaking it into your grant, I mean, that's what I have liked to do, but finding ways to truly do the things that will matter on the back end and not just focus on jumping from one research question to the next, if we actually want to have sustainable or work towards any sustainable change. So, thank you.
Thank you, Dr. Ahonkhai. So, Dr. Pham, I know that they have covered a lot, but there are so many angles to really consider this. I'm sure you have also perspectives on this to share as initial thoughts.
Thank you so much, and thank you for having me. And I think you cover amazingly a lot. I think I can just maybe add a few items, and I do agree about the power dynamics. And Vikram have raised the issues, where does the power lies and who gets to raise the research questions. And I started out my career working to help young faculties develop their research agendas at 3 universities, one in Rwanda and the Congo and Vietnam. And it was really hard for them to start their research career. They didn't have the setup, they didn't have the funding to even write the proposal, so the infrastructure wasn't there. So I see the problem here with these getting and engaging organizations, especially service delivery organizations, to do research is the problems that these practitioners and local researchers see that research is their sense of duty to solve the problem because they see it, but the institution doesn't recognize that it is that needs societal investment. So it's a lack of recognitions that a sense of duty versus a sense that the society see this as a problem that's worth investing. And as Dr. Carey said, that these investments, especially if you want to see from a problem integrate into practice, it takes 10 to 20-year investment. And we see funding cycles as a 1 to 3 year cycles. So you start the phase, and if you're a researcher that has focus and have the institutional support, you're able to carry your whole entire research cycles, 20 or 30 years down the road. But if you don't have that sort of institutional investments or institutional support, then you start one research, you collect data, it sits in your computers, it doesn't get published, you can't present the results, you can't fly to a conference, and then, once you present the data, there's also a lot of engagement that you have to do with practitioner, getting it into guidelines, getting it into practice, and then also getting it to scale up at a global level. It takes a lot of work, but people don't see those cycle as a cycle that's worth investing in every single phase, right? You see part of it, but they think the rest of it is, it comes naturally, or it's your sense of duty, but it's not an investment that we need to invest in.
Yes. So we would like to follow on this aspect of investment before we come back to other points. And I'm sure that from the audience, we'll have so many other questions addressing the aspect that you're trying to cover. So on the aspect of funding, it's sometimes, most of the time, a difficult choice for, let's say, local service delivery organization in the budget planning to even like have a single line in the budget for research and to like support the staff will be like interested in conducting research or to partner with people coming to support the work to conduct research. So in practice, can you speak a bit about how do you see organization, they kind of try to address this issue, investing, and I from the introduction from Professor Patel, we heard that investing in research, so, while there's like limited funding, still create some funding for research or try to maximize what they have available for service delivery. So how do you see this also tension? How do health organizations really deal with that issue as well?
Yeah, I think that's a good question. If you are in an organization like ourselves where we want to build a critical mass of local researchers in our medical schools and interaction with ministers of health, but then you have this scenario where there's very few doctors, there's very few people to go around. The patient-to-doctor ratio is unbelievable. At the same time, they don't have the protected time to even learn how to write the grant. So we think that one of the ways is really providing protected time through working with the ministers of health to really raise research as an agenda, which has been partially successful. At least for the first time in Botswana, the ministry released significant portions of budget to support research. They had done in the past, but it didn't have full-time FTEs. But for the first time, recognizing the value of research. So our own governments should augment what the research partners are doing by creating those positions and infrastructure for research, because of sustainability question becomes very, very important. On the research funding side, like if you look at the K43 like programs, that could help if they are really grown, that can provide years of funding for local researchers. I think that's a good model. K43 mechanism is also a good model that can be used to really sustain research. So there's this tension because you're creating appetite through the work that you do. You are providing solutions. You have created so much demand, but at the same time, the individuals to be trained, they don't have the time to do the research. So we really need to fund that gap, as well as work with our governments and our policymakers to really put research as a critical part of service delivery as well, especially implementation science, but also basic science research.
Yeah.
Yeah, I think I would add that there are some of the data that has looked at this in terms of asking individuals who are interested in research in low and middle income countries what their needs are. I think a lot of the capacity building has focused on training to be able to conduct research, which I think is critical because there's a gap there. But then you have training in a setting where you don't have the infrastructure. So I think in addition to training grants like K43 and D43 capacity building grants, also grants that focus on building the infrastructure are quite critical, so that you have investigators who have the capacity to do research, but also the infrastructure to do so as well. And of course, this is all in an environment where there's no new money necessarily, but I think it's just to note that it has to be both and.
Yeah. So on this aspect of there is no money available to provide the care, the service itself, not enough, then take away some of that money to support research or to creatively come up with solutions. Because as you said, Dr. Moyo, there is the appetite there that you not necessarily create, because you see how people, they have probably less organizational or institutional incentive to be involved in research. It's not necessarily a requirement for the professional development, but people have the kind of intellectual curiosity and interest to be involved in research, but yet they don't really have this kind of support. So in this dilemma of, the whole, Dr. Pham, you mentioned the research life cycle where you have different pitfalls, for the funding aspect in research. So how do you really see this? How can the partnership or support for health organization can really support the different aspect of the cycle?
I'll raise a few additional points because I think you raise a problem where the tensions between you have lack of clinicians, but you also have the need for research. And one of the things that in the department I work in, what we're trying to do is recruit PhD researcher and also statisticians and other disciplines that help clinicians and other practitioners conduct their research so that they don't take all of their time away from the clinical practice, which is really valued and needed. So I think that's one also mentioning, because I think a lot of times when we work in low-income settings, we always migrate toward the MDs, the nurse, and the community health workers. And so I think trying to alleviate some of that tensions, but still engage them in the research in a very meaningful way, I think is really crucial. The second aspect I want to raise is, and it goes back to more of a macro level, thinking creatively about and breaking out the cycles of the 1 to 3 year funding cycles and being more creative about, I think a long time ago when I first started my career 40 years ago, some of the funders don't fund programs unless it was 5 and 10 years investments. And then those cycles has shortened over the years because of compliance and structural issues. So I think some of that long-term investment is great. The other thing is the inequality of the IDC rates.
You talk about that.
Yeah, it's just, and I see the great in 5% to 10% for our partner versus, the 40 to now 60 or 70% here, which I think, doesn't help invest in the infrastructure that you had mentioned. Mm-hmm. And it also kind of disincentivize institutions to invest in these infrastructures as well. So I think those are very controversial. And I think the other thing is also creating some sort of flexible funding that does not end with fiscal cycles. For example, we do research, and we just did some great COVID research and tons of data there, but I cannot get my partner to work with me on the publication because they are working on another research projects that pays for their time, that values their time. And so they can't take their time away because they'll lose income and they can't support their family.
Great. So I'm glad also that you mentioned this approach of, making sure they can have the technical accompaniment, having PhD or statistician because this is an approach we are taking at Partners in Health in Sierra Leone. Dr. Dembe, we just hired a PhD person in our team to accompany the clinician who really have expressed so much interest into research, so that they have a list of what we call research ideas, like tens of research ideas that came from them, and that can really, this kind of support can really have them, accompany them to take that to the level of publication and all that. So another aspect that we would like now, looking at the patient-centered approach for our interventions in general. So in all these considerations, supporting research, trying to find funding and protected time for research, so what are the ethical considerations that we need also to think of in this aspect, in terms of direct service to patient, how do you think that may affect also, and how to avoid that really affect provision of care as well?
Just to mention, invariably, you need to create an environment that you know the research infrastructure provides better care, better patient-to-doctor ratio. So you need to monitor some of the ethical dilemmas that you may experience, a flood of people wanting to be part of studies because they know that they get care. So you need to really be transparent about handling that, working with the local service providers to navigate the intricacies of balancing that you don't create an environment where people want to run to research because they see that they are getting care. And we saw that during COVID, you do a COVID vaccine trial, and all of a sudden you are flooded with participants who want to participate. And at the same time, you just created a demand because there is no provision in the standard of care. So that's a very important discussion to have, to be very transparent about that upfront and try and see how you protect participants. And of course, there's post-trial access issues and intervention works. You think the government will take it over as part of standard of care. They say, yes, we see the data, we see the science, we buy into it, but we are still looking for funding to really get these products available, and negotiating with the research funders to cover that gap becomes very, very critical. So I think integrating and collaborating, making sure that your environment understand that you're answering this question, but there are these issues that need to be dealt with, and how they will cover the gap and how your funders will also cover the gap. I think that's very important.
Good. Yeah. You want to add to that, Dr. Ahonkhai?
I think the in addition to what you said, Dr. Moyo, the idea of what is the definition of the standard of care, and there have been very difficult conversations there. I think if from the perspective of the researcher, who is designing a trial for an intervention potentially to be effective, I've seen really difficult conversations have to be navigated about, shifting standards of care in the community that you are engaging with. And I think sometimes the idea that being able to provide access to comprehensive care is the goal. Sometimes people forget, and the goal is the research and the research outcome. So I think that's an important thing to call out, because I've seen it happen many times, and for, people well-meaning, but sometimes the focus gets lost.
Yeah.
I think also the quality of informed consent speaks to some of what you're talking about, Dr. Moyo, because if I want you to engage in research for the benefit of research, but you may never truly have access to this intervention, am I truly explaining that, and how am I explaining that? And that's a difficult conversation to have as well. So those are the things I would add.
Yes, thank you. So I would like to go back to Dr. Moyo. One thing that you mentioned doing in your work as a good example of kind of partnership and accompaniment of local institution from U.S. academic institution. By curiosity, I would like you to elaborate a bit on the involvement of local people in this kind of initiatives and research. So practical example of that you can really share to see how this really has, you mentioned capacity building, how effective that has been so far, and what more can be done in this aspect.
Yeah, that's a good one. I think for me, what I've seen work is really mentorship. As you see that you are in an environment where most of us were really research naive, and exposure makes a huge difference. So creating an environment of mentorship, structured mentorship, is very, very critical because of the the imbalances and of access and resources and capacity and strength. I think that's very important. Being deliberate about that in the partnership, I think is important, and creating those short-term, long-term plans to build capacity with a view of some of us started in the bench in the basic lab, and with the kind of a privilege that we had to be exposed, now are leading programs, training programs, bringing funding directly to our own institutions when we used to depend on funding being a sub or PI or benefiting from some of the PI-led, and now leading our own is a clear example of that path. Is it happening enough? It could be better. The barriers to get funding continue to increase as compared to the past, but we are seeing a number of local investigators leading studies, including network trials, being investigators, basic science research. Our COVID program is an example of really training basic scientists, but also working with the local university, because that has been a huge learning curve for us to start a pathogen genomics program from scratch to a level where now we are graduating masters and PhDs in that program. But that has really also depended on us identifying lab groups in Boston, in South Africa, to send our students, because you also get overwhelmed by the demand. You have created demand. You have very few people to mentor. So leveraging on the partners to really come in on board, and some of them come with funding, some of them we ship our students there, we ship our samples there. And I think we need to find mechanisms that really truly work. That is not one directional. I think that's bi-directional benefit really works. Having postdocs who spend months there, and that, I think that has created also, changes the culture a bit, and that energy and enthusiasm grows. I think that's a fertile environment. The challenge is always like having funding to get that going. We've created some networks, training and capacity building networks that has helped us within Southern Africa with the 3-4 countries, really focusing on training in thematic areas from HIV/Q to TB genomics to HIV work, and leveraging on the strengths of other partners that have other strengths that we don't have, like a pool for biostatistics. Expertise you may not have, but you have a partner. And so creating those networks really also help while building institutional capacity. There's not enough money indirect to really have protected time for a biostatistician and epidemiologist. So you really need to network. You really find creative ways. But those are the challenges that are in our constrained resources. But you need to be very innovative to be able to answer some of those problems.
Yeah. I don't know how we are doing with time. We have, okay, so that's good. We have 15 minutes. We want to leave some time for the audience to come. But before we do that, Dr. Ahonkhai, I know that you mentioned that you do, in your work, you have significant collaboration into this aspect of research that you do locally in the U.S. and also partnering with global health research, especially in Africa, as you mentioned. So what can you add in terms of what needs to be done, as Dr. Moyo mentioned, to sustain this kind of effort? What structural approach you think can be put in place?
I'll just focus on one, which is community engagement. We've talked about power and position, and I think community we can see as, in this conversation, as community partners of different types, in the international setting or the domestic setting. But I came across this quote as I was looking through papers, is collaborative research, ethical imperialism. And I think in order for that not to be the case, the humility of, as from the perspective of a researcher is, am I asking the right question? Am I listening to the community around me, my partners? And are we focusing on the right solutions? So for me, that has looked like including community partners on all grants and as true partners. And we think of the range of community engagement from consultation to a little bit more empowered engagement to true collaboration, maybe to empowerment at the end of that continuum. And I think it's very easy, if you're the PI or you're the one leading the funds into the equation, that your perspective is the one that's being heard. So I think that has been really, really critical and grounding, even for the work with adolescents and young adults, where we have adolescents and young adults on the study team, and we have to listen when they're redirecting, and it's very difficult because you have your whole plan and you know exactly what you're planning to do, and then a really important community voice says, that won't work, that can't work, that's not ethical, and so we have to be really humble. So I think that conversation can happen with our, co-investigators, co-PI investigators in different settings, but also community partners who I think need to be elevated to the level of investigators when we're talking about conducting research.
Okay, so I promised to go to the audience, but I have one thing that I would like Dr. Pham to probably comment. So one example of direct support, technical support that you mentioned, practically you can have like, students, not students, like PhD, graduate, support research and biostatistician. So those are really some of the things that need to be put in place in addition to what you mentioned, Doctor. So I can quickly mention that in some of the work that I contribute to with Dr. Ivers in Haiti, we were co-chair for the research committee for partners in health in Haiti. So we deliberately put some structure in place, some criteria for research to be conducted. And two of them were like, you need to have a local co-PI, someone in your research study, and also you need to have a significant capacity building component, not just put names or tell people, but a practical capacity building, besides all the things, the relevance of your research and enough funding and this kind of thing. So how do you see this? What else do you think can be also considered to make sure that there's true local capacity that is being built in this kind of partnership in place?
Yeah, so I think the two requirements that you put in place is really crucial, and I think just to add to it, I often set up a goal where I exit the research after a few years and hand it over to my local partners to take over. I think that's a really essential handover process, but also building their capacity to also take over that research. That means that they should have the skills to raise their own money, have the skills to manage that and lead the research team. I think that's really crucial. And then also helping them build the relationships with donors and research track records, because I think a lot of times there are trust issues and there's confidence issues, and I think if we can help set that up and lead and turn over that research locally, because it did start locally, right?
Yes.
And if it's locally, we're just there as as a sounding board, as a technical advisor, but I don't see myself as the lead researcher. I see it as an exit strategy. So we always should work ourselves out of a job.
No, that's really interesting in terms of the part of the research cycle to keep it alive. It's really the handover process. So at this point, I think it's really time. I know we'll have many questions, so I don't know who can help me with that to manage this. So we'll go first with this table. Thank you.
Thank you so much. Very interesting discussion, and I can totally relate with your scenarios. I'm Brenda Katera. I'm honored to be a Women in Global Health Lead Fellow with the Global Health Institute, but I also am the country director for the Clinton Health Access Initiative in Rwanda and with the University of Rwanda as a researcher as well. So I totally relate with many of the scenarios. In fact, I remember one of the early days in my research career when we were applying for an NIH grant and we were focusing on the science and the grant, and we forgot that we need to register for the sum and all those procedures till the very last minute. Needless to say, we didn't submit the grant. But I wanted to go back to an important issue that you raised, Dr. Aima, about the research to policy gap, which is very important because that's a whole goal of us doing research, to really impact the problem and create solutions for policy to be taken up. And one of the ways that we have managed to shorten the gap is to involve the policymakers right from the beginning. Most of our countries have research agendas. We have national public health institutes that are setting the research strategies and are eager to co-create with researchers and other entities. So involving them right from the beginning has allowed them to be part of the process and are able to take up the interventions once the evidence is generated and offer solutions. So if they see there's potential and intervention is effective, bring in the funders right from the beginning as well. And at a global level, I'm also, there have been several initiatives through NIH as well. For example, Fogati has, I'm part of AHISA, Adolescent Health Implementation Science Alliance, that brings together the policymakers from the from the countries, researchers and funders, and let's say in this case for adolescent HIV, are able to create the agenda, but also engage in the research together and create grants that are suited following that. And that really has brought up even PEPFAR along to address some of those questions. So it's really important that we ensure that the research gets implemented into policy and practice. Thank you.
So we'll try to get a balance between the table, probably. So we'll come back to this table. So let's go there. And yeah, I like that it's not just questions, but contribution that you can have into this overall issue that we are trying to debate together. Go ahead.
Hello. Hi, good afternoon. I'm Dr. Jalikatu Mustafa. I'm Dr. Dembi's Deputy Minister of Health from Sierra Leone. I'm sorry, I only have a question.
No, the question are welcome to.
But I was really struck by the fact that all three speakers talked about the importance of building capacity, research capacity in the local communities that you're all working in. And Dr. Aima, I hope I'm pronouncing that right, also spoke about some of the things that are driving researchers in a place like Harvard. So, I mean, having to win grants, having to publish papers, you know, to be promoted or to advance your own careers. Yeah. So I'm wondering, balancing those two, what will be the incentive for researchers from, you know, a place like Harvard going to work in a place like Sierra Leone? What would be the incentive to promote some of the things that Dr. Pham spoke about, building capacity with the local researchers, making connections between the researchers and the grant funders, you know, so that we could also have access to getting those funds, to building our own capacity, to get those funds to promote our own research? What will be the incentive, considering everything you also have to go through, you know, to get your own careers advanced? Thank you.
I think that's where the, you know, for me, you know, being in this room and community of people who are committed to global health, that's where the energy and enthusiasm and positivity is from. People are committed to this goal of health as a human right. So if I am saying that, because we're working on the same issue together, that the funds should be for me, then I don't think I'm in the right, I don't think I'm in the right discipline. So that's what I would say for me. I'm sure many people feel the same way.
Any addition to that?
Maybe just to add that I think collaboration and coordination is so essential. And I see it as a problem both at an individual research level, but also at the macro level, where the funders and interests lie in a singular disease, but they don't look at an integrated approach. So if they look at an integrated approach, it could also promote collaborations that requires a really big research teams, but also create efficiency there. And I think that's a huge problem that I think if that's a way to, you can't create a bigger pie, but at least you can make the pie shareable. The second aspect is, I think we haven't been really creative with the type of funding that is available to us. A lot of fundings are set by one institutions or organizations or donors. So it's bilateral foundations or individuals. But we haven't seen as much pool funding. We've seen it during COVID where, within a year we were able to build vaccines and everything with people pool funding together and create great efficiencies and collaborations and coordinations. But we haven't seen that for other diseases where not only we rely on the public structure, but the private, sometimes at the Brigham, we're afraid to take, pharmaceutical company or private sector because there's hidden agenda. But if it's pool and conditions are created, as I think one of the earlier speaker mentions, conditions where those fundings are not tied and it's pool, then not one person or institution or individuals can create that agenda. And I think that's where much more, creative solution could be had.
Thank you. So we go back to the table as well. Then we go at the back.
Thank you. I am Mary Rosaline. I'm happy to say that I'm a lead fellow in global health. And I have two questions, and they are very simple. So this is Dr. Aima, who mentioned that one of the really good issue is to have the community like a co-investor, a co-investigator, to have, community engagement. So my question is now, we see that so many publications, they are not in the language of the community. How do we guarantee that these communities that have been your co-investor have access to the result of your research? How would you guarantee equity in those research that we are putting in place? The second question is for Dr. Moyo. I want to know how long it will take in Botswana to implement a result of a research. I will give an example. I came from a country where malaria is a big problem. And some investigations shown that the population resists to the drug of malaria that they have actually. But the next bunch of funding came with the same drug that they are resistant to it. While we have the research that show clearly that those drugs should no longer be used because the population resists to those drugs. So if it was in Botswana, how long it will take that Botswana is in different economic situation in Africa? How long that will take to you to implement the research, the result of those research? The other question also is, okay, I take advantage, I have the microphone. So this is the power, I have the microphone, so now I'm having the power to speak. So, well, the last question is also, I think they are related to access to the research. Sometimes we see that an investigator has like an objective to publish, and the research ended there. So what are the next steps that you think as researcher you should take in order for the research doing in Botswana should speak for someone in China and vice versa? How can we guarantee this global health exchange in terms of research? Okay. Thank you.
So we are not too good at time. We are very strict timekeeper there. So what we will do, let's hear from the remaining people we have on the table. We have two. Then I will leave it for the. Oh, we haven't. So, okay. So let's quickly, briefly, very concise.
Thank you. I'll be very quick.
Thank you.
Hello, everyone. My name is Lia Taddasa. I'm currently leading the ministerial leadership program here, and was a Minister of Health for Ethiopia the last 4 years. So it's very encouraging to see now more increasing collaborations between academia and delivery facilities, ministries of health, because our policies need to be driven definitely by evidence. But the challenge we repeatedly see is there are these very important questions designed, research questions to answer a specific interest of, in terms of health outcomes or designs that we need to intervene on, but they are tested first in a very small scope with the funding available, and there is encouraging result, but you want to make policy decisions, you want at least a larger study, but then the funding is not there to expand and test it further. So how do we make sure that this is we overcome this from the beginning in terms of the co-designing to make sure that it's not just an academic exercise, but at the end of the day brings the change we want. Thank you.
Thank you. So please, at the back. So.
Covered, so I'll just predict. I'm Dubai Ravel. I'm here at the School of Public Health in the Med School, and I just want to draw on what Dr. Ahonkhai said about sneaking money for capacity building into grants, and I would just love to hear from all of you about what some of those kind of creative, practical things you can do in parallel with working on the bigger stuff.
Yeah. Okay, so I think we are really at time, and during the break we'll have more time to interact. I'm sorry, Judy. So we'll have our panelists, tell us what they really think quickly about some of those questions, and their final comments as well.
Thank you. Interesting questions. If an effective drug has been found, and how long does it take? Of course, there's a process we've been fortunate that there is a forum for synthesizing evidence through our guidelines committees, where they invite researchers to come and discuss the evidence. Sometimes the evidence then goes through other systems like funding, implementation issues, and we've been fortunate that at least there's agility in the system. For example, in 2016, 1st June, Botswana became the first country to roll out DTG as first-line therapy. It was like, oh, is this an experiment? But it is really like turned out. So that resolve, I think, is there. But it's not always like that. Sometimes you have atorvastatin, very good results from some of the studies. But the implementation challenges and the funding and getting it to really rolled out on that is still something that we are still working on. But at least the science is they buy into the science. Now there's the financing, the implementation. So it's not always like as quick as DTG, but at least there's an environment where the guidelines committees synthesize the evidence. At least the Ministry of Health allows our study teams to present their study findings, engage about the intervention and the possibilities of the intervention. I think that's an important one. I think there's another one about community. I think genuine community engagement and dissemination is very, very critical for all our studies. To the extent in which how they can be involved in publications, that's a good one. But at least making sure that they understand the results in their own language, translating it at least to their level. I think that has led to a lot of buy-in of the research, involving the community advisory board, also being agents of disseminating that research. has also been very important. I don't know if I missed any question.
I mean, we can hear from two other panelists.
I agree with your points about dissemination. I think it's critical and it's part of what we write into our grants for dissemination activities. We're very good at talking to each other through publications, or maybe not even that good because it takes forever to get things published. But I think we also have to be really creative about how we share. There's social media. I think Dr. Carey talked about media and marketing as a critical part of what we all need to figure out how to do. And I think that really needs to be part of what we are doing in disseminating findings back to communities. There are multiple ways to do this, and I've had the opportunity to work now with media and marketing companies in different aspects of research. Young people are always better at social media and marketing, so working with young people is helpful, but I think we have to really be able to share results in a much better way. So I thank you for bringing up that point. And then in terms of, sometimes I do sneak in capacity building, and sometimes I just include capacity building as an aim, where sometimes I get the feedback that this doesn't really, the grant who need some specific thing to advance their career, and we make it relevant, we make it make sense. So I don't presume to know what the thing is that has to happen. Sometimes it's specific to the grant, a training or a workshop that can be helpful, and sometimes it's specific to a team member. But I think capacity building is a part, I think should be a part of what we are all doing and finding ways to make sure that happens.
Yes.
And sometimes you have a big research question, and you have students who want to learn how to do some things. Make sure that you embed them into the learning process. You're answering a big question, but they may be doing a methods optimization for the research that you are doing in the process. You are really building capacity as well as them understanding your study, trying to learn what the question is being answered. So capacity building in various ways. You need to be very creative, otherwise sometimes your research will be seen, they just want to take data and go. So you really need to create that opportunity. You may not have money to sponsor a student or a researcher, but making them, they tag along, they take along in the research, they are exposed, I think is also part of capacity building.
Okay, thank you, Dr. Moyo. Dr. Pham, any final comments on this?
Yeah, just two thoughts. I think, besides sneaking it into grants or putting it as an item, I also sometimes often seek for different fundings that actually support capacity building as one of the goals to supplement the research. So I think donor likes to always add on things. And so if you ask another donor, say, I have a set of fundings for this research and I'm just wanting to create a separate grant for just capacity building, some donors, especially foundations, will provide that. And then just to answer Dr. Leah Tadese's questions about, how do you have like a small scale projects that show promising, and then how do you scale it up and further that research cycle? I think there are different donors that are thinking about that, and the grand challenges are one of them. But I think, as I mentioned earlier about the pool funding, I think it's essential to think about commitment, where if a funder or set of funders seed a small scale project and they see promise, there should be a commitment from them, a written commitment or some sort of commitment that say that if that shows it, then they will fund it further to scale up. And that's what you require. I remember when I first developed one of the software, Kobo, one of the donors said, well, if you show promise, we will fund it for the second phase. And that's what helped launch it to acceptance now. But if I didn't have that commitment, it would never do that. And I think that's what we need, more of those type of commitment, long-term commitment, even if they have to work within the 1 to 3 year fiscal cycles.
Yeah, so with that, I think we will conclude here. And we apologize for not really able to accommodate all the questions and not even have time for the people online. But this discussion will continue, obviously, online and during breaks as well. So thank you very much.